Assalamualaikum and good day everyone. I am Dr. Roslina, FMS from KK Sekinchan Sabak Bernam. PKD Sabak Bernam have been given the task to prepare the module on contraception. As this is a huge topic to cover, we have divided this module into two parts. I will be presenting the first part of the topic in this video. This is the outline of my presentation. We shall begin with a brief introduction to the topic, followed by contraception counseling and the medical eligibility criteria or MEC. I will also be presenting on natural contraceptive methods, which includes lactational amenorrhea method and fertility awareness methods. Artificial contraceptive methods can be largely divided into non-hormonal as well as hormonal contraceptive methods. Non-hormonal contraceptive methods, which includes sterilization, barrier methods and IUCD, will be presented in this video, while the hormonal contraceptive methods will be presented in the second part of this module. So, how do we define contraception? Contraception is the intentional prevention of pregnancy, and this is done either by artificial or natural means. What about family planning? Is family planning the same as contraception? Well, there is actually a slight difference between the two. Family planning allows couples to plan their family, i.e. their desired number of children, as well as the spacing and timing of their births. And this is achieved through the use of contraceptive methods. Next, why is contraception important? Contraception is important because not only does it benefit the mother, but also the baby and the family, as shown in this slide. Now let us look into the contraceptive prevalence rates or CPR in Malaysia. Despite positive evidence on the benefits of family planning, its utilization among Malaysian population is still lower than expected. The 5th Malaysian Population and Family Survey done in 2014 had shown that the CPR is 52.2% for married women, and from this number, only 34.3% use effective contraceptive methods such as the pills, injections, tubal ligation, intrauterine devices or implants. Please take note that the Malaysia's CPR data were only obtained from married women. Therefore, it would be fairly accurate to estimate that the actual CPR is significantly lower. So why is this worrying to us as healthcare providers? This is worrying because it means that women in the reproductive age group who are sexually active and do not want to get pregnant are not using any methods of contraception. This will result in unwanted pregnancies, abortions, as well as maternal or fetal complications during pregnancies. Malaysia's unmet needs for family planning is estimated to be about 20%, or 1 out of 5 women. As you can see in this slide, family planning is one of the pillars of the Safe Motherhood program. In our efforts to further reduce maternal mortality and morbidity, family planning is as equally important as providing good pre-pregnancy, antenatal, obstetric, intrapartum, as well as postpartum care. Women with health problems associated with high-risk pregnancies should be on effective contraception until their condition is stabilized prior to embarking into pregnancy. This is the list of 17 health problems associated with high-risk pregnancies taken from our guideline on pre-pregnancy care published in 2019. Hence, it is important to identify this group of women in our day-to-day practice and counsel them to be on contraception, especially if their disease is uncontrolled. Women who have increased risk during pregnancy and delivery are also encouraged to be on contraception. These are women who are less than 18 years or more than 35 years old, if their last childbirth was less than 2 years, if they are of high parity, i.e. women with 5 or more pregnancies, and following a miscarriage. Now let's move on to our next topic, which is contraception counseling. As there are many methods of contraception available, some healthcare providers tend to present all available contraceptive methods to a woman seeking this service. This is not an effective method of counseling and will result in information overload. Instead, women seeking contraceptive advice should be able to choose their method from an array of family planning options based on the information given by the healthcare providers. This is an algorithm that can be used to assist us in providing contraception counseling to our clients. As with all counseling, one would first need to establish rapport and maintain confidentiality. Next, ask the 4 questions as listed below. By asking these questions, we will be able to eliminate certain contraceptive methods that is not suitable or preferred by the client. For example, do you wish to have children in the future? If the client answers yes to this question, then set aside methods such as vasectomy and tubal ligation. Are you breastfeeding an infant less than 6 months old? If the client answers yes to this question, then set aside the use of combined oral contraceptive pills. Do you have the cooperation of your partner? If the client answers no to this question, then set aside methods such as the use of condoms as well as calendar rhythm methods. Are there any methods that you do not want to use or have not tolerated in the past? By listening to the patient's answer, then set aside the method that she does not want to use. After having eliminated certain methods based on the 4 questions above, arrange the available methods in order of effectiveness and tell your client about these methods. Then, ask the client to choose a method. Ensure the method chosen by the client is safe by referring to the MEC, will or app. Give the client specific information on the method chosen and check for her understanding. And finally, take the opportunity to counsel for STI or HIV prevention in clients who are at risk of STI. For better understanding, please click on the link given in this slide. It is a 7-minute video on effective contraceptive counseling, which is adapted from the training resource package for family planning. Before we end the topic on contraception counseling, I would like to emphasize on a few points that will assist our clients in choosing their methods. Number 1, effectiveness. How effective a method is at preventing pregnancy is a very important consideration for most clients. You can use the effectiveness charts, as will be shown in the next slide, to help describe and compare the effectiveness of the methods that your client is considering. Number 2, how long client wants protection from pregnancy, whether for a year or less, 2 to 3 years, 4 years or more, or whether they want to stop childbearing altogether. Number 3, ease of use. How easy it will be to use. Some methods do not require users to do anything, such as the IUCD, while others require action at the time of intercourse, example, the use of condom, or at specific time intervals, such as the use of injection every 3 months. Number 4, health benefits and possible side effects. Some methods offer important health benefits that may be particularly appealing to some women. Side effects are different from method to method, and knowing them in advance helps a woman decide what potential side effects she is willing to tolerate. Number 5, safety. Few women of childbearing age have serious health conditions that may affect safe use of contraceptives. For women with medical illnesses, the safety of the chosen method can be ensured by referring to the medical eligibility criteria. This chart demonstrates the effectiveness of each contraceptive methods and can be used during contraceptive counseling. The least effective method is placed at the bottom, while the most effective methods are placed at the top of the chart. The percentage indicates the number out of every 100 women who experience an unintended pregnancy within the first year of typical use. Now let's move on to our next topic, which is the medical eligibility criteria or MEC. MEC is a tool to assist healthcare providers to determine if a contraceptive method is safe for a woman to use. The MEC is available in the form of a wheel, also known as the MEC wheel, as well as in the form of an application, which can be easily installed into our handphones. For more information on the MEC, kindly visit the website via the link provided. It is a 6-minute video on how to use the MEC wheel and application. Next, we shall begin to learn about the various contraceptive methods. In general, we can divide contraceptive methods into natural and artificial forms. Examples of natural methods are lactational amenorrhea method, fertility awareness method, withdrawal and abstinence. Artificial contraception can be further divided into hormonal and non-hormonal methods. Examples of hormonal methods are the contraceptive pills, injection, implant, and levonorgestrel IUCD, while examples of non-hormonal methods are IUCD, condoms, and sterilization. Natural contraceptive methods. Lactational amenorrhea method or LAM is a very effective natural contraceptive method. It is only applicable to women in the first 6 months postpartum. For this method to work, one must ensure that number 1, the woman is exclusively breastfeeding her baby, and number 2, her menstruation has not returned. Another natural contraceptive method is called fertility awareness method. Fertility awareness method can be divided into calendar-based method and symptom-based method. Calendar-based method, as shown in this slide, can be further divided into standard days method and calendar rhythm method. Please remember that for calendar-based method to be effective, a woman is required to have a regular menstrual cycle with a duration of 26 to 32 days. For standard days method, a woman is considered fertile from day 8 to 19 and hence should avoid sexual intercourse during this period. Women who opt for the calendar rhythm method must record the number of days in each menstrual cycle for at least 6 months prior to using this method. She then identifies the length of her shorter cycle and subtract 18 from this cycle. This tells her the estimated first day of her fertile time. Next, the woman will need to identify her longest cycle and subtract 11 from this cycle. This tells her the estimated last day of her fertile time. Are you confused? Let's have a look at this scenario to help us understand better. Madam N is a 35-year-old lady who is newly married. She is keen to know further regarding the calendar rhythm method. She has brought along her menstrual calendar for the past 6 months. The shortest of her menstrual cycle was 27 days, while the longest of her menstrual cycle was 31 days. So when should Madam N avoid unprotected sexual intercourse? If the shortest of a cycle was 27 days, we would need to subtract 18 from this cycle. The value obtained, which is 9, means that this is the estimated first day of a fertile time. Hence, Madam N should avoid sexual intercourse from day 9. If the longest of her cycle was 31 days, we would need to subtract 11 from this cycle. The value obtained, which is 20, tells us the estimated last day of a fertile time. Hence, Madam N should avoid unprotected sex from day 9 through day 20 of a cycle. She may resume unprotected sex again from day 21 onwards. Now let's move on to symptoms-based methods. Women using this method will need to monitor their cervical secretions with or without body temperature in order to determine their fertile period. Symptoms-based methods can be further divided into 2-day method, ovulation method, and basal body temperature method. For 2-day method, a woman is considered fertile when cervical secretions are present on that day, as well as the following day. The woman is able to resume unprotected intercourse after 2 dry days. For ovulation method, a woman will need to check for her cervical secretions daily. She should avoid unprotected intercourse when secretions begin until 4 days after peak day. The peak day is the last day that secretions are clear, slippery, stretchy and wet. For basal body temperature method, the woman takes her body temperature at the same time each morning and looks for a rise in temperature of 0.2 to 0.5 degrees Celsius. She should avoid sex until 3 days after the temperature rise. Now let's move on to non-hormonal contraceptive methods. Sterilization. This consists of tubal ligation for women and vasectomy for men. Sterilization is a permanent form of surgical contraception, which is approximately 99% effective. For women, the fallopian tube is obstructed either mechanically or by ligation and excision in order to prevent the egg from meeting the sperm. For men, the vas deferentiae are obstructed by excision and ligation or by cauterization to keep sperm out of ejaculated semen. This procedure does not produce immediate contraceptive effect. Hence, the men will need to use a backup method for a period of 3 months. Complications are usually surgically related. Finally, as this is a permanent method of contraception, there is always a potential risk for regret in the future. Male condoms. Condoms act as a barrier to prevent the meeting of sperm and egg. In addition, condoms also provide protection against STI and HIV. The protection from pregnancy as well as STIs with the use of condoms is commonly known as the dual protection. Most condoms are made of thin latex rubber, which can be damaged by oil-based lubricants. Safe lubricants includes water, saliva, and products based on glycerin or silicone. With correct and consistent use, male condoms are 98% effective. However, as male condoms are commonly used, the pregnancy rate is about 18%. Correct and consistent use of condoms significantly reduces the risk of HIV infection in men and women. When used correctly and consistently, condoms prevent 80 to 95% of HIV infections that would have occurred without the use of condoms. This table shows the advantages and disadvantages of male condoms. Let's first look at the advantages. Condoms is safe and easy to use, has no hormonal side effects, provides dual protection, can be used as a backup method of contraception, can help men with premature ejaculation by reducing sensation, protects women from PID and cervical cancer as condoms provide protection against STIs. Disadvantages of male condoms include less effective than other methods, require partner cooperation, require motivation to put on before any physical contact. Latex condoms can be damaged by oil-based lubricants, heat, humidity or light, and may reduce sensation. Now let's take a quick look on female condoms. Unlike male condoms, female condoms are still not widely used despite being in the market. Female condom is a transparent sheath made of thin, soft synthetic film that fits loosely inside a woman's vagina. Female condom is 90% effective if used correctly and consistently. However, if commonly used, the pregnancy rate is about 21%. Female condoms also provides dual protection. The final contraceptive method in this presentation is IUCD. IUCD is a small plastic device that is inserted into the uterus. There are two types of IUCD, which is the copper IUCD and levonorgestrel or hormonal IUCD. The copper IUCD contains copper sleeves or wire, while the levonorgestrel IUCD contains a hormone reservoir. The copper component damages sperm and prevents it from meeting the egg. while the levonorgestrel IUCD thickens the cervical mucus to block sperm and egg from meeting. IUCD is more than 99% effective and provides immediate return of fertility once it is removed. It provides long-acting contraception up to 3 to 7 years, depending on device. A pelvic examination and STI risk assessment is essential prior to insertion. In general, most women can use this method safely except if: Number 1. She has given birth more than 48 hours or less than 4 weeks ago. This is because limited available data have shown that insertion during this period is associated with a higher risk of expulsion. Number 2, have current STIs such as gonorrhea or chlamydia. Or number 3, have unexplained vaginal bleeding or infection. Please be reminded that you can always refer to the MEC to help determine if a woman with certain medical conditions or characteristics can safely use the IUCD. Please also ensure that consent is taken from the patient prior to IUCD insertion. Use of IUCD is not without side effects. Side effects that may occur are usually associated with changes in bleeding patterns and cramping abdominal pain or dysmenorrhea. Changes in bleeding patterns, which include spotting, light bleeding, or even heavy and prolonged bleeding, may occur, especially in the first 3 to 6 months post-insertion. This is not harmful and usually decreases over time. Bleeding problems and dysmenorrhea can be managed with a short course of NSAIDs during the days of bleeding. Tranexamic acid may be added for women with heavy and prolonged bleeding. Hematinics can also be provided to prevent anemia. If a woman has persistent bleeding problems despite the above measures, please evaluate her for gynecological problems and refer if clinically indicated. If no gynecological problems are found and the woman finds the bleeding unacceptable, remove the IUCD and help her choose another method. When a woman is found to be pregnant while on IUCD, ectopic pregnancy needs to be excluded. Once ectopic pregnancy is excluded, explain to the woman that she is at increased risk of first and second trimester miscarriage, septic miscarriage, and preterm delivery if the IUCD is left in place. Hence, most guidelines recommend that the IUCD is to be removed if the strings are visible. However, removal of the IUCD entails a small risk of miscarriage, and therefore, it is better to consult or refer the case to our gynae colleagues. Complications of IUCD include perforation, pelvic inflammatory disease, and expulsions. The risk of perforation is very low, approximately 1 in 1,000 insertions. This risk is linked to the skills and experience of the provider and can be reduced by training. Patients may present with bleeding and severe abdominal cramping within a few days post-insertion, or they may present later with irregular bleeding or pain at every cycle. If perforation is suspected during IUCD insertion, the patient should be referred to our gynae colleague for further evaluation and management. Expulsion of IUCD is linked to a few factors, such as provider skill, age and parity of woman, as well as timing of insertion. Patients with complete IUCD expulsion may present with missing IUCD strings. On the other hand, patients with partial expulsion may present with irregular bleeding or pain at every cycle. The risk of PID associated with IUCD insertion is low. PID is linked to the presence of cervical infections such as chlamydia or gonorrhea at the time of insertion. Hence, to reduce the risk of PID, women should be screened for STIs and IUCD insertion with help in women with current STIs. Please be reminded that adherence to infection prevention procedures during IUCD insertion also play an important role in preventing this complication. Symptoms of PID include fever, unusual vaginal discharge, and lower abdominal pain. Patients suspected to have PID should be treated with appropriate antibiotics. There is no need to remove the IUCD if the woman wishes to continue its use. With this, I shall end the first part of the topic on contraception. Hope this presentation have benefited most of you. Thank you.